I want to introduce Dr. Dhami, who's our first speaker. She has an impressive resume that's summarized on the back of your program. She's medical director for the Maternal Outreach Mood Services Moms Program. She's a Associate Medical Director, Behavioral Health Services at El Camino Hospital. She's been Chief of Psychiatry there. She's the President of Bay Area Maternal Mental Health. And with nothing more, I would like to introduce Dr. Dhami. Thanks, Dr. Dhami.
Thank you, Dr. Bishop, and thank you all. Can everyone hear me? Okay, good. Um, this morning, as I was getting ready to come here, I was telling my son how nervous I feel speaking in front of an audience. And he said, Mom, just look at them for a minute, and after that, just speak to yourself. And when I speak to myself, I speak very fast. So you all have to slow me down. But I am so thankful and so grateful to be here. This is a topic that's very close to my heart. About 11 years ago, we started the MOMS program at El Camino Hospital. And we started it because we had a patient that came to us and wanted perinatal services, and we didn't have any at that time. And unfortunately, that had a bad outcome. And what happened was we approached the hospital, did a community assessment survey, and it revealed that there was an unmet need in the community for perinatal mental health services. And thank you. And then our physicians got on board, and we started our program. And since then, we've served lots and lots of moms. And I was just mentioning to the leaders here that I had a mom from Salinas once, and she used to drive down all the way. And yesterday, when I was driving here, I realized, wow, that commute must have been something for this lady with her infant to come to our program to get treatment. So we all can do better, and there is a lot more that needs to be done in this field. And I can talk for a long time, but I travel to different places as a part of Marseille, which is a society for perinatal mental health, and I have seen how much better some of the other countries in the world do in terms of perinatal mental health as compared to us. So we'll talk more. These are my disclosures. I did receive an honorarium from Sage Pharmaceuticals for participation in their advisory board. I don't think it's going to influence my presentation in any way. I will discuss off-label use of meds throughout the presentation. So there are lots and lots of myths about pregnancy and postpartum. The media and the society in general, I think, propagate a lot of this. People feel that pregnancy is a state of well-being, and it's also a state where women don't take medications. There are no preventive interventions. Things like postpartum depression don't affect the baby, and they go away on their own if they just get better over time. And there are no long-term consequences of maternal mental health issues. And just the literature speaks differently. And my clinical experience, and those of you who've had the clinical experience of working with some of these patients long-term will know that that's not the case. So I'm going to try and dispel some of these myths today. Pregnancy is not a disease-free state. In fact, women are at higher risk of developing depression and anxiety in pregnancy and postpartum than at any other time in their life. So there are two peaks. One is pregnancy, and then there is a similar peak that happens close to menopause. The prevalence rates for postpartum depression is anywhere between 12% to Santa Clara County says it's as high as 20%. So that's very, very high. If we think about how often we screen people for diabetes and how many times we talk about gestational diabetes and food and nutrition in pregnancy, comparatively, we don't do a great job at screening people for depression, anxiety, bipolar disorder, and psychosis. There is a little bit of a mistake in the last, the psychosis numbers. It should be 0.1 to 0.7%. So depression and anxiety are more common in pregnancy and postpartum than bipolar illness and acute postpartum psychosis. And they do have far-reaching consequences. Then there's always the psychiatric hospitalization. So this was another slide that looks at the hospitalization rates in moms that had just given birth, and there is a spike in the rate of inpatient hospitalizations for new moms. Okay, so this is an interesting study. It has a big number of patients, and this is the second myth that we're trying to address today, which is that moms don't take any meds in pregnancy. So this data includes meds, includes both anti-nausea meds and pain medication, and shows you from 1976 to 2008, the percentage of women that were taking more than 4 meds at any time in their pregnancy, and then any time in the first trimester. If you look at the bars, it's close to 30%. So women take medications in pregnancy. And one of the statements that I like to make is a pregnant woman is a therapeutic orphan in our field, because nobody wants to do research on a pregnant woman. Nobody wants to do any form of clinical trials. They're excluded from most of them. And there is just a dearth of good data on how meds work in these women. Regardless, people take meds in pregnancy. So there has to be a push at multiple levels to include more pregnant women in research trials and get good research-based data for medications and their use. This is also interesting, and a part of me likes to speculate what this would look like if this went to the year 2019. But this is the antidepressant use of medication, antidepressant medication use in the first trimester. The top red line is shows that, and this shows that it's been increasing over the years. And I think if we were to continue this graph, it would continue to climb up. So women get sick in pregnancy, and women use meds in pregnancy. So we've tackled 2 of our top myths. Now the third thing is there is nothing that we can do to prevent. So we're going to switch gears a little bit here. These are US Preventive Services Task Force guidelines. In 2016, they came up with a guideline that every woman who's at risk for postpartum depression should be screened for it and referred for treatment if treatment is available. And then I think what people realized was that there were just so many gaps in providing treatment to these women, starting from the stigma of mental health issues to lack of social support to providers really not having the time to screen the patients, and even if they did, having no place to refer them to. So both ACOG and American Academy of Pediatrics recommended that women should be screened for depression and anxiety disorders when they come for their visits. But again, it ran into the problem that we just don't have the resources or the support system in place to implement that. So these are the new guidelines from US Preventive Services Task Force, and I was really excited about it because they actually talked about preventing something. They said, if you are at risk for depression and you get interpersonal psychotherapy or cognitive behavior therapy, these are moderately effective in preventing depression. And I think that's fabulous. And in the end, prevention of disease and optimal quality of life for all our patients is our goal. So the US Preventive Services Task Force recommendations apply to pregnant women and postpartum women with prior history of depression, history of physical or sexual abuse, unplanned pregnancies or unwanted pregnancies, pre-gestational or gestational diabetes, complications during pregnancy, low socioeconomic status, and lack of social and financial support. So I would like to ask the audience, do you have any such patients in your group that you treat? And if you do, raise your hand, because I do. And this just tells us that these people are at risk for very simple perinatal depression, and simple interventions like talking to them and counseling them, or specific cognitive behavior techniques addressing family stressors can reduce that risk. My presentation today is going to be heavy on the providers. There's a lot of things that providers can do about it. So this is what, so I'm sorry if it comes across as there's a lot more that we can do, but that's what it is. So, women don't use mental health services in the United States in any case. But if they are pregnant, then they are less likely to use mental health services, which is an interesting question because they have more provider contact when they are pregnant or postpartum. Something for us to think about. Can we intervene during pregnancy? And can we intervene more effectively during pregnancy and postpartum? Okay, so this is a slide that I can spend a day talking about, but we don't have a day. But why is it that we're all here this morning talking about a mom who's pregnant and talking about a baby? Because we really have to think about this beyond our patients to the next generation. There is so much research now in psychiatry and epidemiology on what happens when a mom is pregnant and she gets stressed out, the intrauterine environment, and how that has the potential to affect the baby for years to come. So there is, I just attended the American Psychiatric Association meeting, and there was a wonderful presentation actually on the adverse childhood events. And one of the speakers was talking about how trauma in the mother really affects the genes in the placenta. And the placental genes are the genes of the baby. So there is latest research out of Nature magazine. In animal models, they've shown that early childhood stressful events can affect the expression of, it's a genome-wide association study, so affect the expression of schizophrenic genes, and this is in animal models, but early childhood stressful events can affect the expression of a schizophrenic gene in the placenta. And if you really think about it, what that means, it's, a mother's stress can really affect the baby. There is also lots and lots of research now on the link between the brain and the immune system of both the mother and the developing infant. And there are studies that show that if a mother is depressed, the babies have thinner cortical white matter. They have changes in their brain structure. They haven't yet been correlated to specific psychiatric diagnosis, but studies are showing that there are changes in the brain when the mother struggles with excessive stress from mental health issues or other stressors. Dr. Carmen Pariente is a physician out of London who's done a lot of research on the role of inflammatory cytokines in the growing baby when the mom is struggling with depression and anxiety. So we care because we have to worry about our moms. The untreated depression and anxiety can become chronic, and I'll have a slide on that. It can also lead to suicide and infanticide. So part of some work that I did for the past 2 years was I was a part of the California Perinatal Mortality Task Force, and we reviewed all the suicides in the state of California in the past 10 years. These were suicides of women that were either pregnant or postpartum. And it was just, for me, I'm not speaking about the results, but for me, it was just humbling, and it just touched me that how many of these moms had contact with mental health, yet had just fell through the cracks in the system, and it happened again and again and again. And I'm not, saying anybody is at fault here, but I think we can tighten up our system and do a little bit of a better job. And I'm really glad that there's a push to recognize mental health issues and integrate the whole mother-baby dyad better through our system. So it affects the family. It's not just the mom. It really has an impact on the family. And we see that in our moms program a lot. Oftentimes we have dads that come in, and it's so clear that the dad is depressed. And I recently did one of the interventions that we do is a videotaping intervention of the mother and the baby. So we watch the mother and the baby play. And there is a scale called Global Rating Scale by Professor Lynn Murray. So I use that to grade the interaction. And I just recently had a mom who was psychotic. She had been admitted to an outside hospital for about 3 weeks. Her baby didn't visit at all. And when she was playing with the baby basically turned its head away. It was absolutely averse to the mother's reach and contact. And over time, and when we saw that on the video and showed it to her and then encouraged her to use more lights and toys and other things to play with the baby, slowly that interaction shifted. I didn't get permission to show that video here, or else I would have, but I thought I would talk about it. It also leads to increased substance abuse. I've seen this too. I recently had a patient who I have treated over 8 or 9 years who had postpartum depression with every pregnancy, and essentially came back now and, as I was taking the history, revealed that she had used some ketamine and some alcohol because she just wasn't getting better. So there is definitely that potential to develop substance abuse disorders too if these remain untreated. And for the infant, there is the risk of insecure attachment, which we know leads to so many issues. Cognitive language deficits, and of course behavioral and emotional impairment. So this is what we've just talked about, but postpartum depression, and I would say this perinatal mental health disorders are really detrimental to the mother's health and her capacity to attach to the newborn. And there's a lot that we can do to change this. I'm going to move on. So if a woman has depression in pregnancy, there is higher likelihood of the baby having growth restriction. And again, I've seen this clinically. I had a patient that I treated through 2 pregnancies. The first pregnancy, her depression was inadequately treated, very little contact with providers, and the baby had IUGR. The second pregnancy, adequately treated depression with Zoloft and Remeron, a healthy baby. They are now like 6 and 8 years old. And but I just want to point out that untreated depression can have all these risks, and this is very important for us providers to know when we frame the discussion of using meds in pregnancy. And if untreated, this can last for a long, long time and may turn into chronic depression. So these are some of the things that the moms that I work with told me in the past month. Yes, past few days. I met with one husband. The top one is a lady who was depressed and suicidal with a plan to hurt herself. Very high functioning lady. She had been depressed for about 4 or 5 months. And when I met with the husband, he basically said, well, you should just go to the gym a little more. And the patient turned around and looked at the husband, and she had tears in her eyes, and she said, I wish I could. I wish I could get out of bed and go to the gym, but I can't. I don't have the energy. I don't get the sleep. I just can't do it. So this is where family interventions are really helpful, and as a provider, we have to cut through all these mixed messages and help patients and families understand what this is. And I tell all my trainees this, that a mother is not going to come to you and say, I'm depressed, give me Zoloft. They're going to come and tell you, I'm ashamed of myself, I'm a bad mom, I can't take care of my baby, and I feel trapped. These are the commonest things that they will say. But they will never come and say, I'm depressed. So as a provider, it's your job to figure out, even if a mom is well-dressed, well-groomed, and has a laptop and is working on it, that she may be really struggling with depression and suicidal thoughts. I've heard the news that antidepressants are more likely to have kids with autism. So you can look at all the data and show them the data, which is what I do. And then the biggest fear, will I be reported to Child Protective Services? And we've had this happen at our, at our area, in our community, despite all the education we do, because moms have scary thoughts. And so I had a mom who told her internist that she had some thoughts of hitting her baby, just thoughts. 3 weeks ago, she had no desire, no intent. She was horrified she was having these thoughts. And 3 weeks later, she had CPS at her door. So when we have moms with these kind of issues, our therapists contact CPS, and we have letters that we send out to them. So as a provider, discuss birth control with every patient, especially if they have bipolar illness. Frame it as a risk discussion, the risk of untreated mental illness and the risk of taking a medication. And long-term, think long-term. We're not talking today. We're thinking further out. How does this impact the mother and her entire family unit? And then specifically for patients with bipolar illness or a prior history of postpartum psychosis, come up with a relapse prevention plan. And for any of the providers here, if you need any of our resources and plans, El Camino will be happy to share those with you. So this is an interesting slide. This is kind of how I like to think about perinatal mental health, and this kind of guides my thought process as I work with patients. One of the reasons I have this here is because the diagnosis can shift and change, especially to bipolar disorder. So it's really important to keep in mind that what you're looking at may not just be straightforward depression. The Edinburgh Postpartum Depression Scale, we use this for screening all our moms, validated, available in multiple languages. This is our own El Camino Moms Assessment Tool. This looks at the 5 things that I just talked about, the depression, anxiety, OCD, bipolar, and psychosis. So this was a case study. This was actually one of our first patients. Her children, she had, her youngest was 2.5, so she had been suffering from chronic depression for a long time, and she had multiple somatic complaints, and she pretty much had $500,000 workup for her medical issues. She ended up on disability, suicidal thoughts. She came to our program, and she responded really well to interpersonal psychotherapy and Lexapro 20 milligrams. Her depression remitted. She went back to work. She's still working, and did fabulous. So for postpartum depression, I put this thing in red so we can all see it. But these are the common symptoms. So the things I want to highlight here are, one is the intrusive thoughts, which is a lot of moms will have scary thoughts of wanting to hurt themselves and their babies. These are normal. They happen 40 to 60% of the time. Ask your patients. 40 to 60% is a big number. And if 20% of all the people, 20% of pregnant women have postpartum depression, and 40 to 60% of them have intrusive thoughts, it's more common than we think. What I tell patients is it's really common for moms to have these thoughts. Have you had any? Usually they say no. Then we go through the whole interview. We talk about life and other things. Then we come back to the question, and sometimes the answer changes to yes. There is an importance in asking this question, and I think it ties in some ways to what the U.S. Preventive Services Task Force is saying. But oftentimes these moms are so horrified by these thoughts, and they carry so much guilt about these thoughts, that when they share them with you, it's almost like a confessional session, and there is so much relief. That may be the only intervention that they need is having their provider say, it's okay, these are common, these are linked to anxiety, and they get better over time. As your anxiety gets better, these will get better. I also tell patients these are your thoughts, not your actions. The other thing that I want to focus on is I'm a bad mom, guilt and shame. This is where the videotaping really helps, because when they feel the baby doesn't love them, but then they see on the video, the baby will love the mom. It's just the mother's thoughts, unless we have the aversive interaction. Intact reality testing is important because we want to differentiate from postpartum psychosis. And then the last thing are the thoughts of escape. These are very important. Moms will not tell you I'm suicidal and I want to kill myself. They will say, I am trapped. I don't like my life. I think my baby would be okay if I go away. If they start saying that, it's very important to dig deeper and screen. Postpartum OCD, again, a lot of intrusive thoughts, but patients are horrified by these thoughts. So this patient was so horrified by her thoughts of wanting to stab her baby that she had her husband lock up all the knives. She wouldn't bathe the baby by herself. She also refused to go into the kitchen, which was a problem. But once things got better, she did quite well. So we did a lot of work on shame, guilt, lots of psychoeducation to the family, and then they usually respond to high-dose SSRIs. So I tell the providers that I work with, don't give these people 25 of Zoloft. It's not going to do anything. It's not a sprinkling that you put on a cake. You have to treat to remission. Ego dystonic. So the intrusive thoughts or the thoughts of wanting to hurt oneself are usually ego dystonic, which means people are horrified by these thoughts. They are traumatized by them. They don't want to have anything to do with these thoughts. And that, if that is the case, then that's a good thing. And we just have to teach them, educate, teach them how to deal with them, and keep assessing and let them know that they get better over time, because they do. They eventually, what patients tell me is they get less sticky and they spread out more. Okay, so the main reproductive outcome domains, if you're going to prescribe meds, are these. And the important thing to know is that these are affected by untreated mental illness and by antidepressants both. So general rule of thumb, make med changes prior to patients getting pregnant. Involve everybody, involve your OB, partner, family, and treat to target remission. Blood levels can be checked for several medications, so Lamictal, lithium, and we'll go over some of them. And then I recommend no breastfeeding if a patient is on lithium, clozapine, or Depakote. Sorry, back thing. So ECT, which is something we do at El Camino for some of our moms that have bipolar illness, but we don't do as much of, which is unfortunate, is a very powerful and a very effective therapy for women with severe postpartum depression and bipolar illness. I was in India, and they have a mother-baby unit in a place called Nimhans, Bangalore, and they do ECT there. And it's impressive how fast the moms get better. And for the ones that I've done here, I often have almost kicked myself and said, I wish I thought about that earlier. But we just have to jump through so many hoops to get this approved. But it's an effective, powerful tool to get a mom better faster. And it saves lives. So bipolar illness, so patients may present with classic symptoms of bipolar illness. They may also present with a lot of panic attacks, agitated and intrusive thoughts. A lot of times moms will say, I'm having anxiety and panic, and they end up getting started on Zoloft, or which is the commonly prescribed antidepressant. If your mom's not responding to Zoloft, if your patient mom is not responding, and her symptoms are getting worse, or she's getting more agitation, think bipolar mixed, because that may be the diagnosis, even though the patient may keep saying, I'm anxious and I have panic attacks. But that's for the provider to figure out. And patients don't know. So if they're not responding things, so this patient was started on Zoloft, and then she got more agitated and had intrusive thoughts, finally had an inpatient admission at El Camino and responded really well to meds. Eventually we tapered off Ativan, lowered her Seroquel, and did a lot of attachment work with her in our program. And if anyone wants the video or how we do the attachment work, I'm happy to help with that too. For bipolar disorder, know that primary mania is less common than bipolar 2, bipolar NOS, and bipolar mixed. So you may not have the classic manic presentation, but you may have a mixed state. And that's important to keep in mind, again, because providers look at mania. So that's mixed hypomania. This is very, very important to keep in mind. If you look at it, it's hard to if you look at this, it's hard to figure out, is this straightforward mania or not? Because, you know, people feel anxious, mood is labile, up and down, decreased sleep, but then lots of our moms don't get much sleep. Speech is rapid. Okay, I mean, they may have something to say. Shifting tasks, they have so much to do. So this is very important. A lot of moms will present with this, and when they get started on an antidepressant, things get worse. So it's an important differential to keep in mind. And if the patient that you started on an antidepressant med is getting worse, then maybe think about referring them to a psychiatrist, or if you feel up to it, you could add a mood stabilizer, something like Seroquel or Abilify, and see how they do on it. I use Abilify a lot with our moms, and I've seen really an excellent response in low dosages. Typically in this kind of state, somewhere between 2 to 5 milligrams, just such a low dosage, seen an amazing response. Okay, so for bipolar, so if a patient has a prior history of bipolar disorder, or patient has a history of prior episode of psychosis with bipolar illness, or has a family history of bipolar illness, has been on lithium before or has been on some mood stabilizers before, you really want to, and they want to get pregnant, you really want to think about relapse prevention. It is much, much easier to treat this in pregnancy than postpartum, because postpartum often requires psychiatric hospitalization, the mom has to be separated from the baby, and higher risk of suicide. Therefore, it's really important to discuss pregnancy with any woman that's planning to get pregnant and think of a relapse prevention plan. For some patients, it may make sense to stay on the lithium to reduce their risk of relapse. In that case, the OB and the psychiatrist can work together closely, and there are protocols that you can follow on the use of lithium in pregnancy. There is information that you want to discuss with a mom about the reproductive toxicity of lithium and other mood stabilizers, so involve the family, informed decision making. But if a mom has been stable on lithium and she is planning to get pregnant and has had prior history of bipolar episodes, it's really important to come up with a relapse prevention plan. And sometimes you can go through the first trimester without lithium, but then reinstitute it in the second trimester. But it's really important to think through this. So these are some cases of postpartum psychosis. I bring this up because this is a topic close to my heart. Postpartum psychosis doesn't present as typical psychosis. So these patients most likely will not have auditory hallucinations, visual hallucinations, or delusions. They may have some, but it's the classic presentation of postpartum psychosis is what we call disorganized thinking. So it's cognitive disorganization. So if you have a mother or a family member brings a mother in and says, my wife is really confused, she can't figure out how to change a diaper, she can't figure out how to make noodles, she's just acting more and more bizarre. Think about admitting these people, because they will not, first of all, they will not tell you they're psychotic, but secondly, the family may not even know that. And it's associated with a high risk of suicide and infanticide. But the most important reason to admit these people is that it's easily treatable. It is so easily treatable that it's impressive. So think about admission. And we've had patients from our emergency room that were discharged because cognitive disorganization waxes and wanes. So they may look really good in the ER, and then they go home and do something really bizarre, which happened to me once. To one of my patients who I let go from the ER. So don't let these people go. Thankfully, my patient was okay, thankfully, but observe them. That's why we have a 72-hour hold. We can observe people, right? So these are some of the symptoms that patients presented with. License plates outside their car, or the cars parked outside with codes of death. Patient with severe thought blocking. So this was a recent patient I had. She had 3 visits to the emergency room. She had a complete neurological evaluation. She had an EEG done because they thought she had seizures. She was thought blocked. She was so thought blocked that she would sit in her room and stare at the baby's bottle all day long. And the family had overcompensated by getting her a family from India, and everybody was helping out. But nobody realized how severe this was till she said, I can't do this anymore. She responded really well to, this patient responded really well to lithium and Zyprexa. Last, olanzapine. A patient had thoughts that her crying baby wanted to die because the baby was unhappy. So this was a patient that I actually assessed and evaluated, and I learned my lesson. I evaluated the patient with her family, with a live Spanish-speaking person, because they tried their hardest to convince me that she was fine, that they would take great care of her, and she would do well. And I let her go, and then at night she got very disorganized. She thought the pillow was her baby. She tried to give birth through a pillow, and thankfully they called 911, and then we admitted her and treated her. The second case is 2-year history of odd behavior. So I just want to say sometimes patients present with low-grade psychosis with odd behaviors that doesn't get noticed, and they keep having these symptoms till they get worse. Suicide is rare, but seen in perinatal women, and they have had psychiatry contact. Most of the times they are less likely to be receiving, I should say, appropriate psychotropic meds. They might be on some antidepressant, but it's important to know this happens, and prevention can be there. So this is very important. We at El Camino are going to open a women's specialty unit with mother, baby, or perinatal focus, which is going to be second of its kind. Our role model is the one at UNC. And this is something I tell our staff, that's our patients, women that are discharged from a psychiatric ward in the first year postpartum are 70 times at higher risk for suicide. So you have to keep that in mind and come up with good suicide prevention plans. Recommendations. So assess symptoms at several points of treatment to make a diagnosis. I was talking to someone from an OB clinic here. Just assessing once is not going to help you. Assess several times. Remember, anxiety and activation are common symptoms of perinatal mental health issues. Also remember, when you start patients on antidepressant meds, they can get very activated, including with Zoloft, and that may put them at higher risk of self-harm. Psychotic symptoms present as cognitive disorganization and hence can be overlooked, especially if a mom is very depressed or talking about her intrusive thoughts. Assess for disorganized thinking. It's critical. Always assess mother-infant bonding. The child will tell you the story if the mom doesn't. That's what they say in the mother-baby units around the world. Target symptoms, target remission. Don't target improvement, okay, her sleep is better, this is fine. Target remission. And watch out for suicidality, involve everybody. Screening, recognition, and treatment of these disorders is very straightforward. It's not that difficult. Using psychiatric treatments is doable. We can all do it together. And the safety data for most of our meds is comparable to what's available for other meds that are used in pregnancy. But getting patients to appropriate treatment and getting help for our moms is a public policy issue. So I urge the administrators in this room to think more about it. These are all the resources. The NBN2, the number third, this is a free app from the American Psychiatric Association, and they've added a small section on meds in pregnancy and postpartum. I didn't put Marseille Society in here, but M-A-R-C-E, Marseille Society, is a great organization that gives you a lot of resources globally for perinatal mental health issues. And you have access to data from mother-baby units. We worked with the University of South London when we were developing protocols for our unit here, and they have just some fabulous data on infant scales and other things that you can use. And they're more than willing to help. We are a small community of people, so we're more than willing to help anytime. Thank you.